Yeah, so speaking to the quiz, so kind of a couple of goals with that one is to one, the last two questions are probably a little bit more indicative of how the test will go. It'll have 5 answer choices instead of 4, but those are the things I want you to start thinking about kind of conceptually, how these drugs are working, things like contraindications, like what kind of drugs can I not give to these patients potentially, right? And so the other thing though, with those first two questions, the main goal for that one was to try to stimulate those connections between saying, okay, I know I see a fluoroquinolone, right? Because that last question had like 4 different answer choices, right? There were just 4 drugs. And you had to link back and say, okay, well, I know that, this drug is penicillin. I know that this drug is this. I know this drug is this. Those first two questions, the matching is trying to help you stimulate those connections. So that way, when you see those 4 or 5 drug choices on an answer, you can make that connection back. So that way, once you know, okay, levofloxacin is a fluoroquinolone, well, what do I know about fluoroquinolones? Okay, well, I know they cause these kind of side effects. I know they have these drug interactions. I know they have this kind of antibiotic coverage, right? So those are the connections I want you to start making, and that's how things like making mind maps for yourself can kind of help with that. But kind of quizzing yourself like that is also can be helpful. Yeah, it'll be more similar to that. There'll also be more kind of clinical application based off of what we're covering, like in the disease state specific sort of sections here, right? So it'll be more application of like, you have a patient that came in, they have acne and they failed these therapies. What would be a good next step, right? Those would be the kind of things that we may ask more of. But because people have a lot of trouble with antibiotics, just because it's so much kind of early on, and because it is so pervasive throughout the rest of the curriculum, I wanted to put that quiz kind of early on to help you try to start jogging your memory and try to committing some of those to memory. So I'll take a look at it. If there's any high misses or anything, I'll kind of address that and see if they need to be any givebacks. I doubt it. I've done this quiz similar before, and it hasn't been too big of an issue there. So any questions on that or anything else? If not, I will continue on. I got a lot of material to cover, so I'll see what I can do. We talked about acne in last week's material here. Now we're going to get into talking about dermatitis. Now, this is going to be a pretty common sort of inflammatory condition you're going to see here, commonly called eczema in a lot of cases. You also tend to find that people who have things like eczema or dermatitis, they typically have other allergic conditions as well, so things like asthma, things like allergies to medications or substances can also pop up with some regularity there. And you can see here that as far as the pathophysical, a lot of it has to do with the skin barrier dysfunction kind of playing a role here and that being more prone to inflammation. So again, what are your minor or major and minor sort of things you're going to be presenting with? A lot of itchiness, a lot of rash. Sometimes they can have exfoliation of the tissue, especially if they're scratching it a lot. And when that tissue gets all inflamed and red and they're scratching it, what can you also see a risk for? Infection can also be another big thing, right? So then you have to think about, okay, well, do I need to worry about this from an infection sort of standpoint also playing a role there, right? So our goals here for our patients is obviously to provide relief, right? Because again, it's very uncomfortable to have red, itchy skin, so we're going to deal with that. If there's any triggers, you want to obviously identify and eliminate those. That's where your allergist can be really helpful in doing a lot of skin testing to see if there's anything in particular that is sort of triggering that. Those big panels where they can see if there's anything in particular like pet dander or pollen or whatever the case may be. And then obviously when we're looking at this, we want to try to prevent any kind of future exacerbations, any kind of flare-ups, and try to minimize any sort of reactions to treatment. We've already seen that even though some of these dermatologic meds are only being applied to the skin, they can cause a lot of adverse effects, right? With like our tretinoins and things like that. Like what are some of the big side effects you would see? Think about your vitamin A active drugs. Yeah, photosensitivity is a big one, right? This is huge in Florida, right? If you're in the summertime, they want to go out to the beach, but they're like, oh no, my acne meds are causing me to have, practically blister up. It's not good, right? So those are things you want to make sure you are aware of, that these topical medications, even though they're not being taken as a pill, can still have pretty significant effects. So there's plenty of non-pharmacologic things you can do for these patients here. Again, things like applying lubricants or like emollients and other things like that to try to help hydrate the skin can be somewhat useful there. Why do you want to keep the fingernails pretty short? Yeah, they tend to scratch, right? And that can lead to a lot of that more inflammation, more risk for infection, things like that. Obviously, with kids, this can be really tough. Have you ever tried to cut a kid's nails before? It's not great. The first time we tried to do it for my first daughter, Lily, my wife accidentally clipped off a little tiny bit of her skin off the end there, and she thought she was the worst mother in the entire world. She was ready to just call it quits and say, you know what, that's it. I can't be a mom anymore. I hurt my child. I said, she's fine. She had a little bit of bleeding. It's okay. But anyway, sometimes these things can be kind of tough too, right? And obviously maintain good hydration, good tip for anything. So getting into the medications, though, you're going to find that topical corticosteroids are going to be sort of our gold standard here in order to manage this. There's a lot of different topical steroids you're going to find out there. And again, as me not being the expert, I don't do this day in and day out. I'm not going to be so hard-hitting in terms of saying, well, we'll talk about the different categories here in a little bit. I'm going to more focus on the implications of applying these different medications. Like if you're using a very potent steroid versus one that is less potent, what does that mean in terms of side effects and different things you might see like that? We'll get into that. You're going to find that for the most part, you want to try to use the lowest, least potent steroid that you can, right? And sort of our basement there in terms of least potent, sort of minimal steroids is probably going to be hydrocortisone. Most of you probably have seen over-the-counter hydrocortisone creams before. Fairly ubiquitous. It's going to be fairly low in terms of activity. We're going to see for some patients with more kind of severe inflammation, you may need to pick that up and use something a little bit more potent. I'll show you that list in a moment here. But typically for low potency steroids, you want to use the lowest concentration you can. You want to try to avoid some of those intertriginous areas, especially with the higher concentration ones or the higher potency ones. Those tend to cause more systemic uptake of the drug. You're going to see more side effects here. With the low potency ones, you have less of that risk, right? So you can use it on things like the faces, on the face. You can use it for infants. These are okay. When you get to more medium potency steroids, that's where you want to use more areas of, say, thick skin, where you're less likely to see a lot of that absorption there. And then you're going to find that for those exacerbations or those acute flare-ups, then you can kind of pick it up and use something even higher potency potentially for a short period of time, and then you scale it back. The goal always being to use the least potent steroid, the lowest concentration that you can, because that should lead to the least number of side effects. So typically with the topical steroids, they're going to be working just like systemic steroids, but the idea is that if you have less uptake of those drugs into the systemic circulation, less side effects should occur there, right? This is going to be related to the potency of the drug itself. It's going to be related to the duration of use, so the longer term, more likely to have uptake there. The area of the body covered, so remember we talked about absorption through biologic membranes. Increased surface area increases absorption. How about the occlusiveness of the preparation? Which one do you think would have the most absorption? The lotions or ointments? Yeah, ointments, right? Because they stick around for longer, right? They're more occlusive. They have that better staying power. Remember, you have like an ointment that's going to have that greasy sort of feel that sticks around versus, say, like a lotion, which is going to be more water-based, tends to wash away a lot easier, right? Looking at the local sort of effects here, you can see things like skin atrophy, right? If you think about steroids, say more systemically, one of the big things we talk about is impaired wound healing as being a big side effect there, which makes sense why you'd see sort of the skin atrophy that can happen. Same sort of principle there. You can see acne can worsen here, right? So we talked about in some cases of acne that is much more inflammatory, steroids can actually be useful to treat that. More often than not, though, because of its immunosuppressant sort of effects, you can cause more of that bacteria to try to replicate, and that can lead to acne in some situations there, right? Now, if they have dermatitis, you're kind of already treating it with a steroid, but the thing is that oftentimes they'll have reactions to some of the carriers or some of the inactive ingredients in the product itself. Systemically, though, what you're more concerned about if you're using, say, high-potency steroids or places where you have thin skin on the face and the armpits, things like that, you're going to see things like adrenal suppression. So how do you think that would manifest? When I say adrenal suppression, like what does that mean? So like we're giving outside steroids, right? And that's causing the adrenal glands to say, well, there's enough steroids around here, I can stop doing my job, right? And so they'll then shut down production of things like cortisol and things like that. So what do you think that could do for the patient potentially? Maybe fatigue. You can also see issues of things like your glucose may have a hard time maintaining glucose. You may have a hard time maintaining blood pressure, things like that. The problem, though, is as long as you're supplying the exogenous steroids, you're good to go, right? No problem. It's when you take away those steroids abruptly is when you run into problems, because it takes time for the adrenal glands to kind of pick back up in terms of production of the adrenal, those corticosteroids. So again, a bigger problem if you have really high potency agents, if you're using them for a long time, those are where you're going to see more of those problems there. But certainly infections are a risk because of the immunosuppressant sort of effects that corticosteroids have, hyperglycemia, worsened glaucoma, you can see growth stunting in kids potentially. So again, these are why we want to use lower potency, kind of wimpier steroids if you can, because you're less likely to see those systemic effects. So here's a good chart you can check out online. So you can look at that. I'll have kind of an abbreviated list here. When you're talking about steroid potencies, there's kind of different categories here. So mild typically being Hydrocortisone is kind of like the big one you're going to see in that category there, but then it just goes up from there. Typically, the higher the concentration, the higher the potencies, the more likely it's going to be a prescription product. So you can go to any store and find hydrocortisone cream, but you're less likely to find some of these more potent ones, things like clobetasol, things like betamethasone. The reason for that is because they are much more likely to cause side effects that we don't want people just to kind of use them kind of willy-nilly, right? So, and again, I'm not going to get so specific. I'm not going to ask you very specifically which one of these falls into the moderate category versus the potent category. You might find other classes where they ask you that. I'm not going to get quite in depth in terms of that. I'm going to ask more kind of conceptual questions, like, what would be the implications if we bumped it up from a medium to, say, a potent steroid? What could you see there? Or what are some things that perhaps make something go from, say, a low potency up to a moderate potency, right? And so these are things we'll look at here in this chart. And again, the list is huge, right? If you go and work in derm, you're going to become very familiar with your certain subset of steroids that you use. But again, it's very difficult to memorize this entire list here. So that's why I'm going to focus more on the concepts rather than getting into the nitty-gritty on each individual drug there. That won't always be the case. Like when you talk about hypertension and stuff like that, you're just going to have to know all the drugs. But this is one of those cases where I'm going to be a little more lax there. Consider it a gift from me to you. Maybe not. I don't know. Anyway, but what do you notice here about some of these drugs? You can actually find that the same drug can fall into multiple categories, right? So as an example here, you see things like betamethasone. Here you see the valerate form, 0.12%, versus here you notice the ointment falls into the upper mid strength, right? So what do you think that is? From a foam to an ointment. Yeah, because the absorption is more occlusive, right? A foam is going to be much less occlusive than something like an ointment would. So that has an impact, right? So the vehicle that it's in matters, the concentration that it is matters, and also the actual salt form that it's in can matter here, right? So as an example, let me find one. And when I say the salt, what I'm talking about is the second part of the name here. So like fluocinolone acetonide, that is the salt form of it, and you can find if you change that, that can lead to different effects in terms of how potent it is. It can change how lipophilic the drug is, etc. Right? Trying to find a good example here. I think it'll be more clear on some of the lower ones. Hydrocortisone is a good example of this. So hydrocortisone normally is just like the base drug, is the very least potent version of it. But then when you bump into things like the butyrate or the valerate, here's where you're going to see they kind of up the potency a little bit of that medication, right? So it's going to be a little bit more, say, lipid soluble, can cross over easy, has more potent effects there. So those are the things I want you to know. So the occlusiveness of the product matters. The salt form of it matters, the concentration matters, and then obviously where you apply it and the surface area covering will really matter in terms of what sort of potency it falls into, right? And if I say a patient is using something like a low potency steroid and they come in there having an exacerbation, the question is, well, would you switch them to? Well, obviously you would say switch them up to, say, something like a moderate potency steroid, right? So you kind of want to know what to do in those cases there. Or if they had an exacerbation, they've been on a moderate for, let's say, 2 weeks, and now it's kind of gotten back down to baseline, what can you do at that point? Well, then you can scale it back, right? You want to use the lowest potency, lowest concentration you can in order to manage that disease, because that's going to help to limit side effects, right? Okay. Other things we can find, what if a patient's corticosteroids may not be enough on their own? Well, we can use other things to help modulate the immune system to try to decrease that inflammation. And so we can things like tacrolimus or pimecrolimus. And actually, if you're ever get involved with things like transplant, you actually find these are immunosuppressants that we use to prevent people from rejecting foreign tissue that we've transplanted into them. We use these topically, though, in order to help suppress the immune system by helping to decrease things like T-cell activation, mast cell activation, things like that, to decrease the amount of those inflammatory mediators that you're releasing, and will decrease that overall inflammation. Some issues with it, though, and why we don't use it first line is because you can see issues of side effects here where there is a possible cancer risk associated with this, fairly low, but is something to be concerned of. And then if you have a patient with already a weakened immune system, what do you think this is going to do to their immune system? It's going to make it worse, right? It's going to weaken it further, leaving them more at risk for infection. Now, this is another thing you're going to see. These are highly photosensitizing, so you want to make sure people are using high SPF sunscreen. It's the highest SPF sunscreen you can get. Not necessarily. So a lot of it has to do with whether it's a chemical blocker versus like actual physical blocker. Like zinc oxide is like an actual like physical blocker of the UV rays. But SPF 100 would be the highest, right? Because it's blocking 100% of those UV rays, right? Does that sound right, everyone? You work in derm, right? Yeah, does it sound good? Yeah. Anyway, it's funny. My wife is like super into skincare. Like she watches all these like Korean YouTube videos about all the skincare regimens. But my one of my previous advisees, he actually did a 6-month derm fellowship, and then he came to his brother's white coat ceremony, and so I introduced my wife to him, and it's where they just had like a 45-minute conversation, and they're like, blah blah blah. Oh yeah, I use this. Okay, have you tried this? Oh yeah, you should try this. And I was outside of my league. I was like, okay, you guys have fun. We talk about that stuff. Anywho, but yeah, so you want to use high SPF sunscreen because you want to prevent any of those photosensitivity reactions for those patients there, right? So other therapies, occasionally, if it's very widespread dermatitis is extremely inflammatory, we can use things like oral corticosteroids. What's the risk with using an oral corticosteroid versus a topical one? More systemic side effects, exactly right. So you'll provide pretty rapid relief, but you're going to see system-wide sort of effects there. Oftentimes you can see with some patients they may need sort of a tapering. So if they're on it for say longer than a week or so, you may need to taper off that dose to prevent sort of a reactionary sort of inflammatory flare-up. So that's one thing to note. A couple different ones which we'll talk more about, like in the ENT section. We'll talk about these in asthma and things like that. We have things like prednisone, dexamethasone, methylprednisolone. They'll have the same systemic side effects as the topical ones. They're just more likely to cause it because they are being taken systemically there, okay? Okay, so some other topical antibiotics you might run into. We've talked about a lot of these already. Some of them will have topical versions of themselves. What do you think is the difference in terms of activity of a topical antibiotic versus its systemic counterpart? What do you think about like the concentrations you can get with that drug when you use it topically? A lot higher very locally, right? So you can find that even though you may have resistant bugs, if you're applying the drug locally right to the site of action, you can get much higher concentrations than you would otherwise. So even things like bacitracin, which we've been using forever, still maintains good antimicrobial activity because when you're putting it right into a wound, it is very high concentration versus if you were to achieve that same concentration by giving the drug IV, you'd probably kill the patient, right? You can't give that much drug to a patient because otherwise they'd just be all bacitracin at that point. But bacitracin is a very common topical antibiotic we use for cuts, scrapes, anything like that. Very broad in terms of antimicrobial activity. We don't use it systemically in a lot of cases because it does have a ton of toxicity if you were to apply this, say, IV or orally potentially. You may also see it if you're in the surgical realm. You might apply some of these as like wound washes or like an irrigation potentially. You may see that. But very often this is going to be a kind of go-to topical antibiotic. You may also see it used in combination with things like neomycin. Neomycin is a aminoglycoside we haven't mentioned before, and then polymyxin B, which is a different antibiotic class. Be careful though, because if someone has a reaction to say like a triple antibiotic, you have to consider that neomycin is probably the most likely one they're going to have a reaction to. So you can always scale it back and just either use like a double antibiotic or just use a single bacitracin by itself typically. Okay. And again, you may see some allergic dermatitis, but that's more oftentimes related to the neomycin that's included in some of those formulations. And the nice thing here is no systemic toxicity. Right? It just doesn't get absorbed. We also have mupirocin. This one gets used all the time in the hospital. A lot of times you'll have patients who are colonized in their nares with MRSA, and so we can actually use this to help block or to try to eradicate the MRSA. And the benefit of screening patients when they come in and they're colonized with this, and then eradicating that is what, do you think? They spread it to everyone else. Absolutely right. So this is one of those things we test a lot of patients on when they come in-house is to see, do a nasal swab, see if they have MRSA growing there, and if they do, you try to get rid of it, and then that helps prevent MRSA from spreading to other patients, right? You don't want to share the love in that sense when you're in the hospital, right? So very broad gram-positive coverage here for MRSA specifically. We don't have a systemic formulation of this, only going to be used topical. However, because you're applying to the nares, those mucous membranes tend to be a little bit more sensitive than the skin will, and so you may find that you can have some irritation, but most often is due to the vehicle that the drug is in itself. I mentioned polymyxin B just a couple of slides ago. This one's interesting. We actually use this systemically occasionally for patients who have basically kind of run out of other antibiotic options because it's really good for killing gram-negatives, including things like Pseudomonas. It actually works by just kind of punching a hole into the actual cell itself to open up that membrane and allow all the contents to lyse out. Very good in terms of antibiotic kill, but it also kills a lot of our cells too. So when you use it systemically, you see things like nephrotoxicity and neurotoxicity. So we don't like to use it if we don't have to, but topically it's actually pretty good. Not a lot of systemic absorption from that standpoint, which is good. However, if you were to have, say, large areas of open wounds or denuded skin, that's a case there where you could see, when it's applied over a large area, more absorption. You could run that risk, though. Okay. I mentioned neomycin as an aminoglycoside used topically most often. Again, we've talked about these before. We know what kind of toxicities they can cause from a systemic standpoint, but just know that this can frequently cause sensitization. So if you have a patient who has a reaction to like an antibiotic ointment, oftentimes it's going to be the neomycin. The patients may not be able to tell you what it was specifically, right? Because they're like, I don't know, it was Neosporin, right? They say Neosporin, like what can that apply to? They use that to call it to everything, right? Everything is Neosporin to them, just like everything is Tylenol, everything is, Motrin to them, right? So same thing happens here. Very frequently, though, it's the neomycin that's the problem. And we have a couple topical antifungals used as well. Part of the problem you're going to see with topical antifungals is that you have to use them for a really, really long time frame. In terms of how fast fungus grows versus a bacteria, would you say it's faster, slower? It's relatively slow, right? So because of that, it's hard to really have our antifungals really get in there and really have some good kill. And so you have to treat these for a very long period of time, depending on the indication. So things like if you have like toenail infections and things like that, for some drugs you have to end up treating for like 6 months, 12 months. And what do you think it does for compliance? It's not good, right? People don't stick with it, and then you have the infection come back. So that can be a big challenge. So right here we have the azole antifungals. This is one you're going to see used systemically, and we'll talk about those cases in other sections here. But things like clotrimazole, ketoconazole, miconazole, they're actually working, interesting enough, by inhibiting CYP450. What the fungus uses CYP450 for is actually to form its cell wall, right? So it uses that the enzyme in order to form the cell wall. By inhibiting that process, you can inhibit the cell wall formation, thus you break open the fungus, and it will kill it off. What do you think it does in terms of side effects for us, though? Maybe drug interactions. They'll also inhibit our CYP450s as well. So if you see these drugs being used systemically, there's a lot of CYP interactions you have to worry about, right? Specifically, CYP3A4 is a big one. Topically, though, not as big of an issue, which is good from that standpoint. We can see these used for topical fungal infections, vaginal uses, and actually in some cases, especially if you have like a vaginal infection, there's a lot of itchiness and discomfort. Sometimes it can be combined with the corticosteroid, and sometimes that helps with the inflammation, helps with a little bit faster relief there. As I mentioned, for some cases, you may need to use it for longer periods of time, 2 to 3 weeks or so, because of the fact that the fungus just doesn't grow as quickly, and so it's a little bit harder to kill from that standpoint. Okay. Here's an example of one. We have cyclopirox or Penlac. This is actually used for different sorts of nail infections here. It's actually a nail lacquer. What do you think it does in terms of its occlusiveness? If you're lacquering your nails, it's probably pretty good, right? Because it's going to be kind of like a permanent, like you're kind of painting it on, like it's going to stick there for a while. So sometimes that can help in terms of it sticking around for longer, you get a little bit better activity there. However, you do find that, especially in some cases, because patients don't stick with it, it's considered to be not very effective, but that's oftentimes more of a compliance problem with the patient than it is the drug itself not working that great. So it's one thing to note there. A couple other ones, things like naphthene and terbinafine. This is your over-the-counter products like Lamisil and whatnot. They are doing similar things with the fungal wall and helping to prevent a product called ergosterol from being formed, and that disrupts the cell wall and opens it up. Again, you'll see these used for a lot of things like athlete's foot and things like that. Again, local irritations are the biggest problem you see with these because they're topical, so you don't see a lot of absorption. Some other things like tolnaphtate, nystatin, these can be used topically. We use a lot of nystatin powder. The nice thing with nystatin is that we have oral products that are available as well. It actually doesn't have any oral absorption, which is great. So we can use it for things like thrush, candidal infection in the back of the throat, and we have no issues with that in terms of side effects. We will oftentimes use this topically as well. We can see nystatin cream used for things like diaper rashes, or if I have patients who have like a G tube in place and they're having like kind of some candidal kind of growing around that, we can apply nystatin directly to the site, and that can help. So very, very good from that standpoint there. And then we have a couple of topical antivirals, not too many here, but typically we're going to see things like acyclovir being used. Penciclovir is used occasionally, and these can be used for things like cold sores. Herpes simplex is going to be the biggest thing you're going to see these used at least for topically. Now, the way the antivirals work is kind of interesting because they actually will mimic basically they kind of mimic guanine, right? So or guanosine when the virus tries to incorporate that into their DNA, it basically gets incorporated. It doesn't have that sugar backbone on the DNA that it normally has, and so it can't produce any more DNA. So it basically stops the virus from producing their own DNA, which eventually leads to that virus death. And so you typically see these used topically for things like cold sores and things like that. That can be useful from that standpoint. And then one last one here. This one's actually good for warts. This is actually an immunostimulator. And so you're going to see that this actually will help to stimulate release of things like interferon and macrophages and TNF. And so it actually stimulates the body's own immune system to attack the warts, like the virus that actually causes the warts potentially. So you can see these used for a lot of different formulations, even for certain types of cancer cells, right? You can actually use this to stimulate the body's immune system against certain cancer cells to try to get rid of those as well. And again, you're going to see a lot of irritation. And why do you think that is? You're causing inflammation, right? Because you're stimulating all those cells to activate and release all those mediators. You're going to cause inflammation, and so you're going to find that usually the more inflammation there is, the better the drug is working, which isn't great from a patient compliance standpoint, but is one thing that can be useful in some cases there. Okay, so any questions on that? Yes, sir.
For imicrimod,
yeah.
When is that exactly used for? Because I thought the first like we did cryotherapy.
You could do cryotherapy, sure. This might be for more resistant cases, like maybe, or recurrent cases potentially, or things like, maybe perianal warts. I don't know if cryotherapy is indicated for those specifically. I'd have to look into that. I don't know if that's in those sensitive areas, if that might be less preferred. I'm not sure. But again, it's backups, and again, some of these carcinomas and keratoses and things like that can also be used occasionally. Because a lot of topical products you'll see used over the counter for things like warts are usually keratinolytics. So things like acetylsalicylic acid and things like that will actually break down the skin itself. Actually, what a really good home remedy is for wart treatment? Actually, duct tape. Yeah, you can actually just apply duct tape to it, leave it on there, and then pull that off, and then that can actually help over time. There's been some studies where they use duct tape and actually work. So again, duct tape can fix everything, including your warts. So there you go. Any other questions? Yes, sir.
For bacitracin,
yes.
You said it has a higher local concentration. Is there ever times where you put too much on a wound, or how much you put on a wound, someone overcoating it and that causing it?
Yeah, so we mentioned that with polymyxin as being a potential problem. So if you had very large areas, so imagine someone's saying a motorcycle accident and they got drug on the ground, that could be a large area of skin where you might want to apply topical antibiotics. Polymyxin might not be a good option for that because you could see some absorption there. Bacitracin less frequently has issues like that, which is good. Any other questions? Now let's do a 5-minute break. We'll come back and then tackle the ophthalmology section.
I have a question.
Yes.
So, for example, the penicillin question, so the other penicillin would be the contraindication. Is that based on, mechanism of action? So, if you take a macrolide, if you're allergic to it and you have anaphylaxis, is it a contraindication to take another protein synthesis inhibitor?
That's a good question. Is it related to the mechanism, or is it related to something else? Huh? Something else, right? So it's based off of the chemical structure of the drug, right? So if you have something that looks very similar to the body, it can have that cross-reactivity, right? So just like, you may have a particular allergen to a certain cat, but then you go see another cat, the proteins look similar enough to where you have that reaction, right? Even though it may be a little different. It's probably a bad example. But point being is that if you have a reaction to a penicillin, you're going to have other cross-reactivities to other penicillins because they share a similar chemical structure, right? Now, that was an illustration of the point that you could still use a cephalosporin because even though they have the same beta-lactam ring, it's all the other stuff in the molecule that looks different enough. They're very unlikely to have a reaction with that one, right? So that's kind of the point we're making with that. So if you had a reaction to, say, erythromycin, which is what kind of drug? Macrolide. Then presumably you might have a cross-reactivity with something like chlorothromycin or azithromycin, right? But you probably would not have a cross-reactivity with an aminoglycoside. Even though they have the same mechanism, the structures are completely different. Make sense? Anyone else? Fantastic. So let's go ahead and start off with ophthalmology. So, are you guys all okay with continuing on? So the ayes have it? Yes? Get it? Okay, anyway, let's talk about ocular pharmacology here. So it's kind of a good segue from derm into ophthalmology because, again, a lot of the ways we're using these medications will be topical. That's what I'm mainly going to focus on for this lecture here. A lot of eye drops, eye ointments, and things like that. And so a lot of the concepts we saw there will also kind of still apply here as well, as we'll see. Again, there's other ways you can give these medications potentially. There's things like, for instance, you can do subconjunctival injections here. We do that a lot. I have some If you work with ophthalmology specifically, so I have a couple of like ophthalmology docs who have kids who are coming in for like cataract surgeries and things like that. They'll oftentimes utilize a lot of these other routes, things like subconjunctival, retrobulbar. Obviously, these are pretty high risk sort of cases here. And again, whenever dealing with the eye, what is always a risk you want to think about? Going blind, yes, that is always a concern for sure, absolutely. But other things to think about are like infection risk, right? Because the eye is going to be less protected than something like the skin. You want to think about infection risk, right? So you want to keep everything very sterile, which can be a problem, right? Because if you think about using the same eyedropper bottle every single day, like that can potentially get kind of gross, right? Or if people decide to share medications, sounds really gross, but some people do that, right? Anything to save a buck potentially. So again, we're going to mainly focus on the topical administration. You're going to find this has very prompt onset of action, pretty quick there, very convenient, pretty economical compared to some of these other routes. And the issues that you're going to find can be, kind of similar to what we've seen with some of the topical things. Compliance can be an issue. If people don't like to put their eye drops in every single day, they may say, well, maybe I'll skip it today. I'll do it tomorrow. Maybe I'll do every other day. You can also see things like corneal and conjunctival toxicity, which we'll talk about. Some agents are more likely to cause that than other. And then you also can see systemic side effects, right? And so what do you think that is? Besides I gave it away on the slide. Dude, nasolacrimal drainage, right? So when you have tears that are formed, where do they drain out of the eye? The nasolacrimal duct, right? That's a mucous membrane that is highly vascular. Because again, your tears oftentimes either go down your throat as snot or they can get absorbed. Some of those proteins and things like that can be absorbed from that nasal mucosa. So because of that, you have to think about the drugs being absorbed from there as well. So you can see systemic side effects even though you only applied a few drops into the eye. We'll talk about some specific examples of that a little bit later on. How we can prevent that. Most of the times drugs are going to be given as solutions, right? You're going to be given, and one of the things to note here as well is that they're very specially formulated for the eye. So the tonicity is right on point, the pH is right on point. You don't want to screw with that because the eye is very likely to have a lot of irritation. So for instance, if I was, say, out of an ophthalmic product, but I had a very similar otic product, could I use that otic product in the eye? You can do that. What about the other way around? Could I use an ophthalmic product in the ear? 100%. Yeah, we do that all the time, right? So again, the ear is less sensitive than something like the eye would be, and that kind of makes sense just from the physiologic standpoint, right? So you're going to find other things we can use as well include gels, ointments, sometimes like solid inserts potentially. And so the thing you're going to find with some of these thicker, more viscous sort of substances is that the more time they have in contact with the eye, the more likely are to have actual contact with that drug, more drug action is going to happen there. And so that's why we say more time in the cul-de-sac means more absorption. And when I say cul-de-sac, what does that mean? It's like when you pull down your eye, that's the cul-de-sac right there, right? So the more contact you have with there, the more that's a reservoir that the drug can stay in contact with the eye, right? So anyway, even sometimes we'll have things like inserts and implants you can actually put directly into the eye itself to allow for kind of long-term sort of contact with the drug. This might be used for something, we'll talk about ganciclovir a little bit later on, but can be used for things like, cytomegalovirus, retinitis, or something like that. So looking at the kinetics here, you're going to find that absorption is going to be really dependent on the amount of time that the drug is in contact with that cul-de-sac. Again, we're just going to be kind of washing over the eye. And then the more nasolacrimal drainage you have, the less time the drug is going to have to be in contact with the eye. So what could I do about that? What could I do to prevent that drainage? Put your fingers over the nasolacrimal ducts, right? You just close it off, and then boom, your drug sticks around for longer. That'll be one of the things we talk about in terms of administration of ophthalmic medications in just a little bit. You can find that absorption can be changed by changing the formulation. You can do things like blocking the tear ducts, as I mentioned. You can either physically do it, or the silicone plugs can be used. We'll talk about dry eye a little bit later on, how that can be an issue. Cautery, sometimes you can actually cauterize that off and keep tears around for longer. Right? Those are things you can do potentially. Looking at the actual absorption from the nasolacrimal drainage, you can see here, this is pretty highly vascular and can get absorbed, can absorb medications where you can see systemic side effects from drugs you're just applying directly to the eye. So that is one thing you do want to note. Also, it avoids first pass metabolism, right? Why does it do that? Yeah, skipping the liver, right? So it doesn't have that first pass metabolism like you would see with like the oral route potentially, right? So, and remember, the more contact time you have with the eye, the more absorption you're going to have, but other things can play a role here as well. So for instance, in terms of surface area, I can't really do a whole lot about that, right? Because the eye is the size that the eye is, so that's the surface area you're dealing with. But what other things could I do to increase absorption? Can't change the thickness of the eye, can't do anything about the surface area of the eye, so what can I change? Medication, maybe how lipophilic it is. Also, what else? Remember, the concentration difference is important. So by increasing the concentration of the drug, more absorption should happen as well, right? Now, normally, once a drug gets absorbed through the eye, you can find that it gets distributed just like any other drug might throughout the body. However, sometimes you can find cases where drugs will actually accumulate in the eye, which can potentially cause problems here. So here's an example of a bullseye lesion you see with this old school antimalarial drug called chloroquine. You actually see that just accumulate there. Again, may lead to vision changes, may lead to issues in the long term. Once they are absorbed systemically, though, they get eliminated and metabolized just like any other drug would, so no changes there in terms of those drugs. Some of these drugs you're going to see we used in the eye, we also can use systemically. They get treated just the same in the body once they're absorbed. Okay, so let's talk about a few antimicrobials. This will be pretty quick because we've already covered most of these classes here. We'll just talk about anything specific with applying them with the eye. Now, as I mentioned, when applying them directly to the eye, what is the concentration like compared to if I were to take a tablet of one of these medications? Way higher, right? So you're going to find some differences there. So for instance, some drugs may not have a whole lot of activity for a certain kind of bug, say orally, will have really good activity in the eye because the concentration is so much higher. I can get above, what's that value called you have to get above to start to kill the bacteria? The MIC, right, that minimum inhibitory concentration, I can get above that because I have such high concentrations there in the eye. Now, and again, you're going to see these complaints all the time. People come in complaining of eye infections quite frequently. A lot of times it could be viral, but in some cases bacterial. Or bacteria could be playing a role here. And so depending on sort of how involved the eye is, whether you have just a preseptal, which is fairly simple to say like a postseptal, you have an orbital cellulitis, this can be much more involved and require potential admission to the hospital, potential IV antibiotics. And so a lot of times your selection is going to be dependent on just how involved the eye is, how bad the infection is getting in terms of its spread. And so you're going to find that depending on the clinical setting, these can also predispose to bacterial infections, things like preceding trauma. If you have a patient who came in from a car wreck and then you got drug on the ground or something like that, that could be playing a role there. Age can be a factor here. Obviously, in the extremes of age, very, very young versus very old. And in fact, have you ever seen a baby born? What's the first thing they do to their eyes? Glop on some either erythromycin or gentamicin ointment. Why do they do that? Avoid infection. Why would the baby get an infection in the eyes? From the birth canal, right? They're picking up bacteria potentially from that birth canal, and so they want to prevent that because the eyes, again, are a very easy site for bacteria to take hold versus any other part of the body. So those are things to consider. If they're immunocompromised, they may also be at risk for things like fungal infections, which can be really problematic, viral infections that most immunocompetent individuals would not have to worry about. And as I mentioned, the involvement of disease will play a big role as well. So just know that it may require oral parenteral antibiotics very frequently, though, especially like in the urgent care sort of fast track sort of setting. You're going to see that is most topical is going to be used most frequently. But for those more small, mild, and peripheral infections, we like to treat topically because, one, it has very limited systemic bioavailability. So side effects systemically are not going to be a problem. They have high local concentrations. However, one of the drawbacks is that you do have to dose it more frequently. So some of these you're going to find maybe dosed 4 times a day, 6 times a day. And what does that do to your compliance? Goes into the tank, right? So frequently you might choose a drug because you can use it less frequently because that helps with the compliance, right? Especially imagine giving eye drops to a kid. It could be really tough, right? So anything to help with that compliance is going to be a big deal. Most of the ones we use are pretty broad spectrum, and resistance is not as big of an issue. There's going to be some cases where that is a problem, as we'll see. But because you have such high concentrations, resistance is less of an issue there, okay? And then frequently, we don't get cultures for these. We just go ahead and treat empirically and go from there because most of the time our antibiotics are going to work. And then also it's unlikely to be sort of an atypical bug unless it's something like, an immunocompromised individual or something. So talking about conjunctivitis, again, you can find they have this, mild hyperemia, it's kind of purulent discharge. Very frequently, though, it's not bacterial, right? Viruses, environmental stuff, contact lenses is a big deal. Have you covered any ophtho in your medicine courses yet? You think contact lenses, what bug do you always think? Yeah, good. You're already making that connection, right? We'll talk about what drugs are going to be good for that. But again, a lot of typical sort of respiratory bugs like, H. flu, streptococcus pneumonia, things like that can be playing a role here. But also remember, like, what's constantly touching our eyes potentially? You have itchy eyes, your fingers, right? So again, anything could be there. You could have gram-negative bugs, you could have staph, you could have anything potentially because people's hands are just naturally dirty, right? Obviously, our goal, though, is to get rid of that infection, prevent any complications from occurring. So here are the topical antibiotics we're going to be using here. Now, what do you notice about most of these? We've seen them already for the most part, right? We've already covered a lot of these. So you already know the mechanism of fluoroquinolones, right? You already know the mechanism of a macrolide, right? I hope so. You just took a quiz on it, right? Absolutely. So anywho, point being is that we've already covered a lot of these, so we'll talk about them specifically in use as topicals for ophthalmic infections and any sort of unique things there in terms of just mainly focusing on the systemic aspects. In terms of macrolides, these are very, very commonly used. Most common is going to be erythromycin ointment. And again, what do you think is the benefit of using that ointment versus, say, the solution that you see with azithromycin? What do you think it does to how often you have to give it? You may have to give it a little less often, which can be nice. That is going to be a little bit of an exception here. You actually find azithro has a longer duration of action, mainly just due to its half-life being a little bit longer there. But again, another thing as well is if you have a kid who's fighting you, you're trying to put eye drops into a kid's eye, you may not get a whole lot of contact with that drug there. The nice thing with ointments, though, is that even if you just get it in their eyelashes, it still is going to be hanging around. You can still find some good activity for those drugs there. So that's one thing to consider, is that ointment's going to be a little bit better for kids potentially, just because they're going to fight you and they're going to have a hard time putting those drops in or putting those ointments in. And we know like a good way to like hold a kid down, or how to like keep them from fighting you too much. Ever heard of a papoose? So we basically turn them into like a little kid burrito, take like a blanket or something, just kind of wrap it around. They're fighting you and everything, but it helps out quite a bit putting those in there. I had one patient who was coming in. This was up in Duval County in Jacksonville, and kind of the further west you go in Duval County, the more kind of trucks and trailers and that kind of environment. So it's fairly podunk, right? And I come from that kind of environment, so I can speak to that. Point being, though, there's two little boys that were playing out in their yard, and so they didn't have anything to play with, so they took an empty bottle of Drano and decided to toss that back and forth for whatever reason. And then guess what happens? Cap comes off, kid gets Drano in the eye, and so it's very, very harsh sort of chemical irritant. So kid had to come in, and this kid was screaming bloody murder because it hurt so bad, but we had to flush the eye out. We had to get the irrigation going, and so kid screaming bloody murder, couldn't even get anything in contact or can't get close to the kid's face. And so eventually the kid all of a sudden just goes dead silent. We're like, what happened? Did the kid die or something? Like what? Going in the corner like, no, I just gave some ketamine. Kid was knocked out. We got our Morganlins in. We got that thing flushed out. Everything worked perfect. So sometimes you even can't use physical restraints because they're fighting so hard. Sometimes chemical restraints can be useful in these cases here. I would not recommend that on a routine basis, though. Anywho, the nice thing though is that also notice with the macrolides is that we talked a lot about drug interactions for macrolides systemically because of the CYP inhibition. Notice here topically, do we have to worry about that? Because again, the concentrations systemically are going to be negligible, right? And again, just to show you how you're going to be dosing these things with liquids and solutions, you're going to be dosing in drops, right? So when you look up your dosing, you'll see apply 1 drop, 2 drops, whatever the case may be. What do you notice about the ointments? It's going to be based on length, right? So the length of the ribbon of the ointment you're going to be applying there, right? So maybe say half an inch, maybe say a centimeter, something like that. Now again, how good do you think your patients are going to be at estimating those kind of distances? Probably not great, but again, that's kind of the nice thing here is that you're not getting extremely accurate doses. As long as some drugs get in contact with the eye, it's probably fine when it goes with an ointment, right? So this is a big thing you'll see. Obviously, if it's a little bit larger patient, you may say, let's go with, say, an inch, right? Versus a kid, you may say half an inch. It just depends on the size of the patient, how severe the infection is. But again, notice the duration or the frequency here, up to 6 times a day, which can be really difficult depending on the patient there. Now, azithromycin, you'll see here, it actually give, interestingly enough, you give 1 drop in the affected eye twice daily for 2 days, and then you do 1 drop daily for 5 days. What do you think? Why do they dose it more frequently up front? It's almost like a loading dose, which is kind of strange. We see that same thing when you have like oral azithromycin, like a Z-pack, and you take 2 tablets the first day and then 1 tablet on days 2 through 5. So kind of doing the same thing there. So azithro sticks around for a little bit longer, has a little longer duration of action than what you would expect just based off of how long the actual liquid's there in the eye. Anyway, macrolides, or at least erythromycin is really nice because when it's in that nice ointment formulation, it's very soothing to the eye. And so even if it may not be truly bacterial, a lot of people will get this anyway because it kind of helps to deal with some of that stinging and the irritation. And so that can be quite useful there. Does anyone know what you would do if you ever had someone get like super glue in their eye? And they glue their eye shut? Can actually use erythromycin ointment because of the oily base that it's in. Because it's an ointment, you can actually find that if you apply that to the eye, it'll actually help to loosen that up, and eventually it'll just kind of open up on its own. So if you ever call it cyanoacrylate blepharospasm, so cyanoacrylate's a super glue, and basically they glue their eyes shut. So you can give erythromycin ointment, and that will loosen that up eventually. So little tidbit: if you ever work in the ER and a kid glues the eye shut, you can say, "I know exactly what to do," and you'll say, they'll say, erythromycin, the kid doesn't have an infection. You say, it doesn't matter. The vehicle I want, it's not the drug itself, right? So something to think about. Anywho, azithromycin tends to be much more expensive than erythromycin, so it does not get used as frequently. But maybe if a patient was needing less frequent dosing, maybe if compliance was a big issue, then maybe use that. Another one here, we have trimethoprim and polymyxin B. Where do we see trimethoprim? Yeah, as in Bactrim, right, with sulfamethoxazole. How do those drugs work? Folic acid antagonist. Polymyxin B, though, is a different mechanism, right? It's going to actually kind of punch a hole in that bacterial cell. And so, again, using dual mechanisms here to get better synergy. So this is called polytrim. See this used with some occasion here. Again, frequent dosing. Notice here in terms of side effects for all of these ophthalmic products is going to be what? What's kind of the common thread? They can all cause eye irritation, right? So again, depending on the patient, depending on the formulation, they can all cause irritation. Just notice almost like the nausea, vomiting, diarrhea of oral meds, right? Any of them can cause that potentially. But it's nice, no drug interactions, irritation. That's really the biggest problem. You can use sulfacetamide by itself. So this is very similar to sulfamethoxazole. This is sulfacetamide. Now, what would be a potential concern if maybe I had a patient with, say, an allergy? So they have a documented sulfa allergy. They might cross-react with this. You can actually see worsened inflammation in the eye. There could be some cross-reactivity there. So one thing you might want to note, and again, just know this is also going to be one of those folic acid antagonists, similar to sulfamethoxazole. Again, be very wary of that. Otherwise, no big interactions, no big concerns from that standpoint. We also have bacitracin ointment. We talked about that for topical uses in terms of on the skin. You can also use this in the eye as well. Again, irritation is the biggest problem. Again, ointments, think about like who might be a better candidate for an ointment versus a liquid. Things like that might come up on the exam when you're trying to think like what's the best dosage form for my patient. You just want to consider that. So for instance, we mentioned like kids might be a better option for ointments. Those are things you want to kind of consider. Okay, so now we have the fluoroquinolones. So most of the other agents we saw are pretty broad spectrum. However, most of them did not have any significant coverage against things like Pseudomonas, right? And we mentioned Pseudomonas you want to be thinking about, and what kind of patients? Contact lenses, right? So this is where the fluoroquinolones are going to be playing a big role here. We have things like ciprofloxacin, ofloxacin, levofloxacin. We've covered most of these before. Remember, they're inhibiting DNA gyrase and topoisomerase to help to cause more DNA strand breaks for the bacteria. We will use this more for conjunctivitis, not usually as a first line, but if we have that history of the contact lens where we'll think Pseudomonas, this is going to have good coverage against that. Also, we have corneal ulcers. This could also be another good treatment for that potentially. Just know you're going to see white precipitate with ciprofloxacin, kind of a unique thing there. They may think, hey, this looks a little funky. They may already have kind of purulent discharge, but now they have this white precipitate. Like, what the heck is this stuff? Just let them know it's part of the drug. It's just what happens with it. And then why do you think you'd have an unpleasant taste after installation? Yeah, it's all that nasolacrimal drainage, right? As it goes down the back of the throat, it may have that taste that can pop up there. So that's why you can see that with some drugs. Now, again, these are going to be much more expensive, so that's one thing you definitely want to note with that, but these are preferred. So for Pseudomonas, if you have that concern, these are going to be the go-to drugs here. However, because they do get used a little too much, you can see resistance that are popping up there. So it's one thing you do want to know. Don't use this for every single conjunctivitis that comes in. Reserve it for the patients you really are thinking of Pseudomonas here, right? And again, depending on the severity of the infection, you may need to dose it more frequently, less frequently if it's less severe. But usually for the first 2 days or so, you kind of hit them a little bit harder, and then you can kind of go less frequent after that once the infection starts to kind of get a little bit better, the patient's feeling a little bit better there, okay? All right. Aminoglycosides could also be used occasionally. Now, these are going to be used kind of as a backup, say, to the fluoroquinolones because they will get Pseudomonas as well, just like we saw systemically. However, though, you can see that they can actually cause this reactive keratoconjunctivitis, and they themselves can cause corneal ulceration. So that's another reason why we don't want to use these for, say, long-term use. The reason why they would be sort of a backup to the fluoroquinolones. So, again, you may see that done used clinically occasionally. Okay, some other ones we have here. So looking at antiviral drugs here, there's not too many that you're going to find from the antiviral standpoint being used ophthalmically. These are going to be more reserved for patients who are immunocompromised, patients who have more things like cytomegalovirus or say herpes virus, things like that. If you have just like a typical viral conjunctivitis, it's mostly due to like adenoviruses and things like that. We don't have any good treatment for that. Mostly it's just supportive care, make sure they're washing their hands and maybe some eye ointment or tear replacement or something to help with that, to help soothe the eye. But other than that, there's not a whole lot you do for those type of viruses, right? A couple that we do have, and what you normally find is you have patients who are immunocompromised and they have one of these viral infections. Very frequently, you're going to be using parenteral therapy, oral therapy, something more systemic. So the ones I highlight here are going to be the things that we actually have ophthalmic products for that you'll find using. That's the ones I'm going to focus on for this lecture here. We'll talk about the other systemic antivirals in other sections, but these are the ones I want to kind of focus on, right? So we have trifluridine and then ganciclovir be the two big ones from this section. All the other systemic ones we'll talk about later. So trifluridine is going to be used typically, and actually from all the antiviral standpoint, they have very similar mechanisms. They basically try to incorporate themselves into the viral DNA to prevent further elongation, and that eventually kills off the virus itself because it causes enough damage to cause apoptosis eventually. This is going to be good for herpes simplex viruses, and then one kind of notable sort of side effect with this one is this punctate keratopathy. So again, if you're to do a fluorescein stain on the eye, you would end up seeing this kind of develop, and that's basically the drug itself kind of depositing itself into the eye. So that's one notable side effect. And the ganciclovir I mentioned, this is actually good for patients like cytomegalovirus. If you have like an AIDS patient who's severely immunocompromised and they develop a CMV retinitis or something, this is good. This is that one I mentioned before that's actually an implant that you could actually place into the eye itself and have good long-term sort of release of that drug there. Now, would you guys ever be the one to put that implant in? The ophthalmologist would be doing that. It's a surgical procedure, be done under anesthesia most likely, right? Okay, we don't have very many in terms of ocular antifungals. There's actually only one that we'll talk about here called natamycin. It's the only commercially available one. Very frequently, if they have an ophthalmic fungal infection, that usually indicates they have pretty significant immunocompromisation. They probably need more systemic therapy, and we'll talk about those again later. But people who are at risk, other than those that are going to be dealing with immunosuppression, tend to be patients who have had preceding trauma. Maybe if they have some kind of chronic ocular surface disease, maybe like an inflammatory disease, or chronic contact lens wear. Could be a thing you would see if they come in with that conjunctivitis and maybe you're treating them with, say, a fluoroquinolone and it wasn't working, then you may need to consider it could be fungal potentially, right? So that's kind of the backup thought you have if it's not improving. And that's where something like natamycin could come into play here, right? Now, this one's going to be working by basically increasing the cell membrane permeability, so it'll kill the fungal cell there. And it gets pretty broad spectrum in terms of the different types of fungus it can treat. Don't memorize this whole list here. Just know this is going to be very wide spectrum and can kill a lot of different types of fungus. Okay. Again, nothing spectacular in terms of adverse effects or drug interactions. So some precautions here when dealing with patients with an ocular infection. Whenever they're presenting with an eye complaint, you always want to make sure that you perform a visual acuity. Why do you think you want to do that? I'm looking to see if they're getting any better, any worse. I can follow up with, I can look at previous visual acuities to see, okay, is this wildly different than what they're normally at? Those are things you want to think about. Obviously, document any allergies to medications. See if they have any previous eye visual acuities you have to document there. And then obviously, if vision's getting worse, you need to go ahead and consult ophthalmology, right? So kind of know when you're outside of your scope and say, okay, let me at least get the expert in here to kind of see if there's something else going on. Now, how do we administer these eye drops? So the very most important tip to ever give a patient when they're giving eye drops is what? Wash your hands, because your hands are dirty, and that's probably what gave you the infection in the first place, right? So make sure you wash your hands, soap and water, most important. And then anytime they're dealing with like a dropper bottle or anything like that, don't have actual direct contact with the eye itself. Why do we avoid that? Because you're contaminating it, right? And those need to be sterile as best as possible. They come sterile, but we can make them unsterile very quickly if you start to touch the eye that's where the cooties are, right? And so then we'll have the patient tilt the head back, and this is specifically for like liquids and solutions. We have them tilt the head back, and then you pull the lower eyelid down to form a pocket. That way you can actually hold the medication there. And then taking the other hand, go ahead and apply the drops, again, close to the eye as you can, so that way you don't end up missing. Because a lot of people, what do they tend to do when they're trying to give them to themselves? They tend to blink, or they tend to like kind of jerk their head away. The people are very squeamish about eye stuff. But again, have the other hand close, not too close, obviously touching the eye, and then go ahead and place the drop in there. We'll talk about using multiple drops when we get to the glaucoma section a little bit later on, but this is kind of just for general application. After that, you can have them close the eyes and then go ahead and close off that lacrimal duct, right? Go ahead and put their fingers over that, and that will then allow for the drug to stay in the eye, have contact there, and because again, it's only working as long as there's contact with the eye itself. 2 or 3 minutes or so. Patients probably won't actually do that full length of time, but you tell them 2 or 3 minutes, and then they should be good to go. Wipe away any excess, and then wash your hands again. Okay, pretty straightforward. Now, in terms of drops versus ointments, you tend to find that ointments are better for kids or those you might think have poor compliance. And as I mentioned, even if the drug is on the eyelashes, it's still making some contact there, and so you still can get some activity. However, the one big downside of the ointments is what does it do to your vision? It's going to blur it, right? Because again, you have that's kind of oily sort of base there in the eye. It's going to blur your vision for about 20 minutes or so. So make sure patients aren't like applying it and trying to go drive or something, right? Although it usually appears like most people on the road probably have something in their eyes, it seems like most of the time, right? But anyway. When you're doing gels and ointments, it's a similar process, but do I have to worry about closing off the nasolacrimal drainage? No, because the stuff is too viscous. It's not going to go undergo any of that drainage for the most part. But basically, you'll squeeze the ribbon of medication into the pocket itself. No need to cover it up, and no need to really hold anything for any period of time. If the drug is there, it's pretty viscous. It's going to stay there for a while. Now, as I mentioned with contact lens wearers, they should discontinue use when they develop a conjunctival infection here, and they do not want to resume use until they've had no discharge and the eye's not inflamed for about 24 hours or so. Now, should they reuse the old contact lenses? No, get rid of them if you can, or at least very well disinfected prior to, but I would just say just get rid of them if you're able to. And then, unfortunately, they say to get rid of the eye makeup. Why is that? It's probably contaminated, right? So if you have that really expensive stuff from like Ulta or something like that, say get rid of it, and they probably won't, and they'll get reinfected, and so it can be a little bit of a sick cycle there. Anywho, that's why I only buy the stuff from Walmart, so that way it's super cheap, I can get rid of it, no problem, right? So, just kidding. Yeah, really, and then when I get like the feathers going or whatever, right, they talk about that. Is that a thing? Feathers? Feather your eyes? No? No, not eyelash, but isn't there something where they like do something like weird? I don't know. I'm outside of my depth. I'm going to pull back. I'm going to pull out. I'm going to get back to the drugs. Yeah, you know what I'm talking about. Yeah. I don't know. I saw it on Reddit the other day, but anyway. Okay, so we talked about the actual infectious processes here. Let's go ahead and talk about more of the allergen component of it, right? So if you have an allergic reaction to something like pet dander, like potentially makeup, like potentially anything you might come in contact with. Again, this is the same sort of inflammatory reaction you would see with any sort of allergic reaction, whether it's with the skin, systemically, anything like that. It's mainly going to be these IgE antibodies that are basically binding to immune cells and causing a lot of things like degranulation of mast cells and things like that. So there's a lot of inflammatory mediators getting kind of released all at the same time, which is why you see this vasodilation of the eye. That's why it gets nice and red. Because you have those blood vessels kind of opening up. It's going to get edematous. You're going to have a lot of tearing. It gets very itchy. What's the main kind of chemical that causes a lot of that itchiness? Histamine's a big one, right? So we're going to see drugs that are going to be very specific to trying to block some of these actions here. Also, another thing we could do, though, is instead of mainly focusing on the mediators that have been released, what if we could prevent the mast cells from degranulating in the first place? That's what we're going to call mast cell stabilization. We'll look at those as well in just a little bit. But basically by using an H1 receptor antagonist, and we'll talk more about these in terms of their use systemically when we get to the ENT section, I think a little bit later on, probably in the next section of the class. But what these are going to do is they're going to help to decrease that capillary dilation, so those vessels will constrict more. It'll decrease the itching, and it'll decrease the swelling that goes along with that because the vessels are more constricted. A couple agents here, and when I say MCS, that just means mast cell stabilization. So some of these will also have some of those properties where not only do they prevent the histamine from interacting with the receptors, but they also can help to keep the mast cells sort of stabilized to prevent them from degranulating and releasing more histamine and whatnot. So some of the ones we have here include the zelastine, imidastine, epinestine, ketotifen. This one is notable because it's available over the counter. So you might find some patients who are using this to self-treat themselves. Now, what do you think is the problem if patients have red, itchy eyes, and they're using these over-the-counter medication for a long period of time, but it's not getting any better? Is there any issues with that? Could be irritating the eye more. You also have to think about what if it's bacteria, right? What if there's an infection there that they don't know about and they're not treating? So this is why a lot of the instructions on these over-the-counter products, they do not use for more than a certain length of time, because if it's not improving, then you probably need to go see a provider to get it checked out, right? So that's why you'll see a lot of those things like don't use for more than 2 weeks. You can use it for more than that. It's just the fact that if you're still having to use it for more than 2 weeks, there's probably something else going on. You probably want some kind of licensed provider to check you out, okay? And the olopatadine is going to be another common one you're going to see there as well. So again, you're going to see fairly frequent dosing with the antihistamines here. Note that these will work while you're having an acute reaction. So some people may use these as needed if they're having a reaction, or they may use it seasonally depending on what their particular trigger happens to be there. Typically, we allow them to use it for about 2 full weeks before you really start to see sort of maximal effect. So kind of make sure they know to take it for at least that period of time. And obviously, you're going to find that in terms of adverse effects, you're going to see some irritation, some headache. And actually, one thing you might find is increased ocular dryness. Now, what do you think that might happen? Think about it, if it's blocking all that histamine and causing vasoconstriction, like that decreases the tearing and the edema. Well, it also could do the opposite effect too and cause a little bit more dryness. And so that's why you want to at least watch for that. Again, no big drug interactions, and typically these are going to be preferred over the standard mast cell stabilizers, which we'll look at in a second. So for the most part, these are going to be kind of your go-to in terms of dealing with that sort of allergen-based conjunctivitis. Now, the mast cell stabilizers, do you think these will work in the middle of an acute allergic reaction? Why not? Mast cells are degranulated, so they're not really going to do a whole lot of good. These are better for more sort of long-term prophylactic use. If you know a patient, say during certain seasons of the year, they're just going to be more prone to having this allergic conjunctivitis, maybe they'll take it just for that period of time. But typically you need to do it before a reactions actually happen in order to make sure those mast cells never degranulate in the first place. So use less frequently, but they could be a good backup if patients are unable to use antihistamine for whatever reason, maybe sensitivity or something like that. I have a couple here, things like cromolyn, lidoxamide, and metocromyl. These are going to be the more common ones you're going to see from that standpoint. Again, less preferred, but maybe used as a backup. Again, give it about 2 weeks or so to really see full effect here, but these are not going to be useful for acute symptoms. They also have to be used more frequently than the antihistamines do, which is not ideal. And so, again, overall, less preferred. Again, very similar adverse reactions as the antihistamines there, so nothing strange there. Okay, so what would you do? Oh, yes, ma'am.
So just to reiterate, so the mast cell stabilizers you don't want to use after you've already had an allergic reaction, but
Or if you're in the middle one, like,
or in the middle.
yeah.
But an antihistamine you can use.
Mm-hmm.
Okay.
Right, because that's when you're having the histamine being active, right? So you want to go ahead and block those receptors and prevent it from doing its thing, for sure. Yep. So other things we could do to help deal with, really injected sort of hyperemic eyes, we can use either a combination of vasoconstrictor plus antihistamine, or just maybe a vasoconstrictor by itself. And so here's where you're going to get into things like your vasoclears or your Visines. People have probably seen like commercials for these before. Most of these are available over the counter, and these are going to be able to help with that conjunctival edema. Basically, the 3 agents we have here include tetrahydrozoline, we have nefazoline, and then we have phenyramine, which is an antihistamine plus nefazoline itself as a combination drug, right? So phenyramine is going to block histamine receptors. So if there's an allergic component to it, that can be very useful. And basically what these are going to do is just directly activate alpha receptors on those blood vessels in the eye to cause them to constrict, right? So by causing the vasoconstriction, it gets rid of that redness, gets rid of that edema there. However, this is something notable, and we'll talk about a very similar group of drugs being used nasally in the ENT section later on, but you do not want to use these for, say, longer than 2 weeks, okay? The reason why that is because you get a rebound hyperemia that can develop when they stop taking it if they've been using it for a while, okay? Now, why do you think that might be? If I'm chronically... It's almost like a withdrawal effect, yeah, but think about like the way the receptors are reacting to having a chronic agonist around. If I have something around constantly stimulating those alpha receptors to constrict, what does the receptors do in response to that? They upregulate or downregulate? It is an agonist at the alpha receptors. They downregulate, yeah, because they're overstimulated, right? So they're saying, hey, I got way too much stimulation here. Let me downregulate. Let me get rid of some of these receptors here. Well, what happens when you take away that drug all of a sudden? What normally stimulates alpha receptors? Your sympathetic nervous system. What do you think? Like, what's flowing when you got like your fight or flight response? Adrenaline, right? You think adrenaline, like epinephrine, norepinephrine, right? Those are things that normally stimulate those alpha receptors to cause vasoconstriction. Well, when you take the drug away, and then you're just relying on your natural epi and norepi to cause that constriction, but all the receptors are missing, or a lot of them are missing, what happens? The vessels just blow wide open, right? So you get this rebound hyperemia, okay? And that's directly related to the fact those receptors are now downregulated, okay? We're going to see the same thing. Anyone ever heard of the drug Afrin? Afrin's going to be a nasal spray that they use for nasal stuffiness. And this will do the same thing. You get really bad rebound nasal stuffiness if you use it for too long. We'll talk about that later. But this is the same class of drugs essentially. Okay. So big point of that. If you use it for more than 2 weeks, you got to taper off your dose. You can't come off of it all of a sudden. Otherwise, you get really bad rebound hyperemia. Okay. And again, if you see no improvement with these agents here in 3 days or so, you need to go see a provider because in the end, it's more likely to be something more serious, something you may need to get checked out in terms of like infection or otherwise. Okay, so what else could we do for inflammation if our antihistamines aren't working, if our vasoconstrictors aren't working? What else could we do? Well, we have NSAIDs that we can use in the eye itself. And we've talked a little bit about NSAIDs previously, I think at least to some degree, but how do these drugs work? Remember? Yep, they decrease the activity of the cyclooxygenase enzyme or COX enzyme, right? And so normally what you find during an inflammatory reaction is that you'll have the cell membranes actually release this product called arachidonic acid, and this is kind of the precursor for a lot of your inflammatory mediators, things like your prostaglandins and thromboxanes and prostacyclins, all these different things. Basically what your NSAIDs are going to do will inhibit this conversion, and it prevents a lot of these inflammatory mediators from being formed in the first place. So just like when you stub your toe and you have inflammation at that site, you take ibuprofen, right, to decrease that inflammation. This is going to do the same thing in the eye, okay? Now again, this is not going to be used for your run-of-the-mill, typical sort of, environmental sort of conjunctivitis, things like that. This is going to be more sort of reserved for patients who are maybe not responding to that, or more often than not in the post-operative period, because we want to maybe decreasing inflammation after, say, cataract surgery or something like that. So a few agents we have are going to include bromfenac, we have flubiprofen, and then actually these two here, diclofenac and ketorolac, you'll actually find get used systemically pretty frequently, right? Diclofenac actually has a topical gel you'll see used occasionally. We'll talk about that when we talk about osteoarthritis. It also has oral formulations. And then ketorolac is actually a really good go-to intravenous or parenteral NSAIDs. You'll see that used all the time in the ER for patients who are coming with pain. They'll usually get a dose of Toradol, and it works really well for them. The eye form is called Ocular, so again, you'll find different brand names depending on the formulation that it is. Okay. So really good for postoperative inflammation or really refractory allergic conjunctivitis. Again, these would be prescription only for sure, right? Anyway, so what can you see with these? We can see things like, keratitis, intraocular pressure increases, right? Who might that be bad for? Glaucoma, right? And we'll talk all about intraocular pressure a little bit later on. And then a lot of irritation seen with this. So again, this is something really going to be probably if you're working like family practice, urgent care, things like that, you're probably not going to be prescribing these. You may find patients who are using these from their ophthalmologist, right? We also have glucocorticoids that we can use, and again, these are even more powerful in terms of anti-inflammatory actions because they're working at the site of the nucleus, right? So before you even produce arachidonic acid, it's working even higher up in the pathway here. So these are the most powerful and good for like really, really refractory allergic conjunctivitis here, but more often than not, we'll be using these for after surgery and things like that for the most part to help kind of control that inflammation there. So what are some things we can potentially use this for if they have severe ocular allergy, as I mentioned, post-operatively? Those are going to be the most common sort of uses there. However, you're going to find that in some cases we actually will do this intraocularly, but more often than not you'll see the topical formulations being used as well. And again, glucocorticoids have very, very powerful anti-inflammatory actions because they are working to prevent the activities of things like your eosinophils, your macrophages, all these other cells are going to be inhibited because you're actually working at the site of the nucleus to prevent any transcription for those kind of pro-inflammatory sort of proteins. So very powerful, but they also take a little bit of time to kind of kick in and work because they do work at the site of the nucleus. So typically for ocular glucocorticoids, these are only for really refractory symptoms because of the problems you can see with this. So this can include things like cataract formations they can cause. They can cause intraocular pressure increases, which can worsen things for like glaucoma for patients. You'll see infections, right? Because just like systemically, steroids tend to be causing an immunosuppressant effect. They do the same thing in the eye. And what do we say about infections in the eye? It's more likely to occur anyway, just because it's a less protected site than you would see, like, say, on the skin. Delayed wound healing, corneal ulcers. So because of that, we typically rely on very short courses, kind of called pulse therapy. We're using them for a short period of time, deal with the inflammation, and then you put them on something else they can stay on more long-term potentially. Okay. Here's some agents you're going to see used here, things like dexamethasone and prednisolone. Some of these you're going to find will be used either IV or orally. We'll talk about those later. But here we actually find some that have these stars here. These are actually a little bit newer generation corticosteroids used for the eye. Things like fluoromethanol, rimelexone. These are considered to be called soft steroids, and they call them that because they have lower intraocular pressure increased risk, and so these would be better for patients with glaucoma. So sometimes you'll see that being used occasionally. These would be a little bit better from that standpoint. And then what do we do? Just kind of run them. Oh, yes, ma'am.
Can you expand a little bit on refractory symptoms for the day?
So if you were, say, for instance, you're having ocular allergies, right? You're having an allergic conjunctivitis, say, due to pollen in the air or something like that, right? And then so you tried using, say, an ophthalmic antihistamine, and that wasn't working, okay? So your symptoms are refractory to the antihistamines. I'm going to now try, maybe I get prescribed an NSAID. I tried that, and it's still not fixing the symptoms. That's refractory now to the NSAIDs. Now I got to use something like a steroid. So again, basically your symptoms are not being treated with that therapy. They're then refractory to that at that point. Yeah. Anyway, so what do we do for dry eyes? You know, anyone remember these commercials from back in the day? I'm aging out my students more and more every single year, so fewer and fewer people remember this, but this is old Ben Stein commercials. We talk about the dry eyes. I'm sure maybe some of you have seen Ferris Bueller's Day Off. Yeah, okay. Bueller, that's the same guy. So, anywho, so using all these commercials for clear eyes and things like that. But there's a lot of medical conditions that can cause a lot of ocular irritation and can decrease tear production. This includes things like chemical burns. So, like that kid who got the Drano in his eye would have similar issues with this. Anything that can alter the ocular surface or tear composition can be a big problem here as well. And there's actually a lot of autoimmune conditions that will do the same thing. You know, so things like rheumatoid arthritis or vitamin A deficiencies can all lead to really kind of irritated dry eyes. So what do we do with this first? Well, you want to treat the underlying disease if you can. So if it's an issue of rheumatoid arthritis causing sort of a systemic inflammation, well, deal with that inflammation first, and that will usually help with the eye as well. And in some cases, though, we can have physical interventions, like we may do those punctal plugs. We may do, say, surgical occlusion of the lacrimal drainage. That's that cautery I mentioned you could do to kind of keep tears around for longer. And then quite frequently use things like tear substitutes. So we'll use either hypo or isotonic solutions that will have things like electrolytes and surfactants and things like that to help keep them in the eye, kind of stick around for longer. And then the agents you'll find that are most frequently used for this include things like something called BSS, which is a balanced salt solution. It's kind of designed to be similar composition to the tears itself. But thicker agents that stick around for longer include things like carboxymethylcellulose, hydroxypropylcellulose, and polyvinyl alcohol, or otherwise known as artificial tears. And so one way you might actually see this being used you may not think about is imagine if you have a patient who, say for instance, can't blink, right? Many patients who couldn't do that. Well, what if you were paralyzed, right? What if you had a patient who was, say, in the ICU and they were being mechanically ventilated and they had to be on a paralytic in order to keep them from being, bucking the vent essentially, so they can't, oxygenate appropriately. So sometimes we'll give them paralytics, and what do you think it does to their ability to blink potentially? They can't do it, right? Because you're paralyzed all over. So one of the things you have to think about is the fact that these patients, they're sedated, they're paralyzed potentially. They're not going to be able to blink their eyes. They may not even notice that they're having dry eye. They can develop things like corneal ulcers and corneal abrasions and things like that. So we actually have to make sure that as part of the things we think about in giving these patients as prophylactics is make sure we're giving them tear replacements and make sure we're keeping their eyes nice and moisturized. Otherwise, by the time they wake up, they may have vision problems that we didn't, we caused for the patient because we didn't think about that sort of thing. So again, little cases we may not think about it potentially. Anyway, and then another way we could deal with dry eyes as if they were so refractory even to all those other things would be if we had an immunomodulator. So cyclosporin, kind of similar to what we saw with like tacrolimus being used topically for to help suppress the immune system. This is kind of doing the same thing, and this is actually another agent you'll see systemically being used for transplants and whatnot. But this is a good agent here that helps to decrease things like interleukin production and T cell activation, and will help. So if it's inflammatory in nature causing the dry eye, this will help to suppress that and will help to kind of increase tear production. It's actually pretty good at that. Problem though is it does cause a lot of irritation in and of itself, so a lot of patients will have ocular burning, kind of a foreign body sort of sensation, so it may not be preferable from that standpoint, but if they've kind of failed everything else, this might be something you might want to add on for those patients there. Okay, so I don't know that I'm going to have time to make it through the entire glaucoma section in the 5 minutes I have left, so I'm going to say that the end of the test material, because you guys have a test next week, right? Yep. End of the testing material is going to be here. Okay. So anything before this slide you consider to be testable. So all the derm stuff, ophtho up through glaucoma, or up to glaucoma, and then the antibiotic stuff, okay, is going to be testable. I'm going to go ahead and cut it here because I want to see if anyone has any questions. Do you have any thoughts so far? Yes, ma'am.
I have a question.
Yes.
As far as for the exam, do we need to know doses for this stuff?
I'm not going to ask you a dosing question. If I include any doses on like an answer choice, just assume it's correct, right?
Is that same for like concentrations?
Yeah, I'm not going to put something on there that's like not. I'm not going to try to trick you. I'll be like hydrocortisone 0.75%. I'm like, oh, that doesn't even exist. Trick you. Like, no, I'm not going to do that. But it'll be more questions like, well, why might you like? Why is one concentration better for this type of patient than another, right? Or if is increasing concentration a good idea here? Maybe decreasing concentration, or maybe keeping it the same. Who knows, right? Those are kind of things that I'd want you to know. If there is dosing, it's going to be more to do with like, well, why do we give this antibiotic so frequently, or why do we give it less frequently? Like, what are the things that inform why we use a drug like we do? I'm not going to ask you, is zithromycin 500 milligrams on day 1 or 250, right? That's not going to be that granular. Yes, ma'am.
Is this test 50 questions?
50 questions, all multiple choice, 5 answer choices. I'm not sure how much time they'll set up for you, but it'll be pretty standard for whatever your other tests are.
Is it going to be equally weighted, including the quiz material, or are you going to be like weighting it towards what we
No, I'm going to keep it, so it'll be probably close to 50% for the antibiotic section. So 1 and 2 will be probably about 50%. And then derm will be roughly 25. This will be roughly 25-ish. It'll range a little bit, but it depends on when I'm writing the questions, what I come up with. Yeah. Yes, ma'am. Oh,
Erythromycin is good for like the supervised. Would all macrolides be good, or
good for.
like if said it suits the eye?
You wouldn't want to use azithromycin because it's a solution, so it wouldn't really stick around as long. Like the erythromycin, just being it as an ointment, it has that better kind of staying ability. It's much more viscous, and that in and of itself is more soothing. It's not the drug itself; it's just the vehicle that it's in. Yes, ma'am.
I have a question. So, in regards to the exam, do you provide like vignettes style, like clinical questions where we should be able to interpret and give you the response?
Yes. So I'm not going to have you like diagnose anybody necessarily, right? So that's not really my realm of expertise. So if it's something like a patient presents with, I'm going to tell you like what it is essentially, right? But you still have to make a decision on like what's the best treatment choice potentially, So if I said someone, was presenting and say febrile neutropenia and you were concerned with Pseudomonas aeruginosa infection, right? Which one of these agents would be appropriate coverage for that? And it might have like clindamycin, like vancomycin, ampicillin, and say meropenem, right? And so your job is to be able to identify which one of those would have appropriate pseudomonal coverage, which would include meropenem, right? So that would be the answer choice for that one, right? Or if I said, you're worried about a MRSA, infection, which one of these would cover that? Okay, so that could be things. So yeah, those are the type of questions. There'll be a blend of things that are a little bit easier in terms of like just basic recall of facts, like which one of these is a folic acid antagonist, or which one of these can cause, I'm trying to think, ankle pain in a patient. You want to think about those kind of things, like those kind of unique sort of hallmarks, sort of side effects or mechanisms and things like that. What other questions do you have? I'll check the board real quick to see if you have anything.
I have a question.
Yes.
On if we have to let you just get the neutropenic fever,
Okay.
what answer?
Oh, sorry, I mentioned it. So in that case, meropenem would be the agent that would cover Pseudomonas, right?
Because it covers Pseudomonas versus the neutropenic fever being the stuff in the glyphosate?
Yes. So again, from that section itself, I'm not going to get super granular on hitting individual indications because we'll talk about those other sections, right? So for like pneumonia, for instance, we haven't covered pulmonology yet, so I'm not going to ask you very specifically. A patient comes in, they're diagnosed with pneumonia, what's the best treatment choice? Like we haven't hit that yet, so I'm not going to ask that necessarily. But if I said, a patient's coming in, you were concerned they were diagnosed with an atypical pneumonia, which one of these would cover your atypical bugs, you need to figure out that, okay, it's probably a macrolide, right? So those are the kind of things you want to be able to identify.
But so for like the eye thing, you could say this patient comes in with dry eye, and then you have to know the medication to treat the dry eye.
Yeah, so which one of these would be appropriate for a patient with like, chronic dry eye due to, or say like for instance, like a patient comes in and they've tried, every single, tear replacement under the sun, they have a history of rheumatoid arthritis, which one of these would be most appropriate to try next, right? And so you say, oh, cyclosporin might be a good option for that patient, right? Any other questions? Study hard. If you have questions, please reach out to me early. The night before is usually not the best time. I'd like to get back to you, but who knows, depending on my children, how rowdy they're being. Nothing else. I will see you guys next time.